Good evening, everyone. Tonight we are at Orthopraxis Leumann in Basel, Switzerland.
And you're watching Achieving Optimal Performance Facebook Live interview about foot or ankle which needs help.
I am Lina. I'm a personal trainer and functional diagnostic nutrition practitioner.
I'm Martin Kum and a sports chiropractor.
We are two people who have more questions than answers in their professional lives, and our plan is to travel the world, visit the best healthcare experts, ask the questions, find the answers, and share the knowledge with you via Facebook Live interviews.
During every Facebook Live interview, you can always ask questions, share your opinion. If you have something you want to ask from the expert, just write them in the comments. We will see them throughout the live interviews, and we do our best to answer these questions during the show. If you have a friend who you think should be watching the show, write their name in the comments and they will get a direct link to the live feed and they can join in and ask questions too.
Before we get to introduce our tonight's expert, let's watch the intro.
Tonight's live is very special, I think, because not very often you have a chance to have a Facebook Live interview or have somebody as good as my today's the guy I'm having an interview with. And the reason why I think it's really interesting and really useful for many people is he is an orthopedic surgeon, and it's not often you get a caliber guy like this in your living room, wherever you're watching this. So I don't talk too much, I give the word, and I'm hugely thankful for this opportunity, Andre, to have you here. So may I introduce Dr. Andre Leumann.
Martin, thank you very much. Good evening, everybody. It's a pleasure to be here and talk about my most topic I like most about the ankle joint and sports injuries of the ankle joint, and I'm sure we can discuss some very interesting cases, give you some good ideas about how to think, how to solve problems and get your athletes back on their level they want to be back.
So basically, before we go into this more details, and we talk a lot, and we actually will go into quite the depth of the foot anatomy and also surgical procedures. And before we go into this, Andre, talk a little bit about yourself, so our viewers also have idea who you are. Because I had the pleasure for past, I think, 2 or 3 years already to know you, and I've also been in the operating hall with you, and I had the chance to see how you work. So it's been a great pleasure for me, and I know how good you are, what you do, but give us a little overview who you are and what you've been doing.
Yeah, thank you. I have two entrance to this topic. It's on the one hand it's the orthopedic side, and on the other hand it's the sports medicine side. These are both things I'm very interested in, and it was during my med school that actually I started to work on my medical thesis, and my medical thesis was about chronic ankle instability, so I jumped into it. The reason why I have chosen that topic is that I was an athlete in orienteering competition myself, being member of the national team, and as you can easily imagine, orienteering, running through the woods, they have a lot of problems with the ankle, they have a lot of injuries. So I was in my medical thesis studying the problems of chronic ankle instability in the orienteering national team, and that was the way how I came into this world. And from that on, it right started. I did my training in orthopedic surgery at the University Hospital in Basel, but I also spent some time at other places, and I spent like 12 months at the Human Performance Lab in Calgary. After finishing my training, I actually was for quite some years in a leader position at the university hospital before I now changed to my own private clinic, where I could even improve my quality of work, my quality on how I deal with patients, and I'm very happy to help patients as much as possible. Beside my orthopedic daily life, I am the team doctor of the orienteering national team, one of the team doctors, and therefore I am working a lot with athletes, and I'm also a member of the executive board of the Swiss Society of Sports Medicine. So I really am into both sides, into orthopedic surgery and sports medicine.
So as you can, when you're listening to this, you can understand that today it's going to be a very different chat compared to what we had 4 weeks ago in England when we started the project, and we went to see a psychologist. We talked about the brain and how the brain reacts to pain, for example. Or the second option, we check an interview we had with Joel Proskowicz about the lower back biomechanics. Today we're going to go into a field which not many people can have access, especially if you are a chiropractor or a physical therapist or osteopath or anyone really working in a medical field. Is you don't get these opportunities to learn and then hear the orthopedic surgeons talking about their everyday lives and how they make decisions to take the surgery or not, because it's, as we go into depth, it's not an easy decision, I guess, right?
Yes, it's not an easy decision, and it's of course a decision that has to be well thought. It has to be balanced in between advantages and disadvantages. But basically I have much more basic tasks that has to be solved, and I see in my daily life quite a lot of patients where I think that the basic work of the doctor has not been well done, and this is something I really want to give to you. It's important to listen to the patient, because as athletes even more than other patients, but athletes, they can really tell you what is their problem, what do they have, and it takes time to listen to them. But this is, for me, it's the main key for success, is to listen to them and to solve that you are able to solve the problem. This is the first thing. And the second thing is you have to examine your patient. You have to take the foot or the ankle or the knee or the shoulder or whatever. You have to take it in your hands. You have to feel it. You have to examine it. And this gives you a very important idea about the problem. And it's not about high technological diagnostics. It's not all about MRI. Basically, it's about listening to the patient, and it's about examining your patients. This is very important. And based on that, you can start to find your diagnosis, and you can start to treat your patient.
Good. Now, before we really go into it, we will go around the world and visit the best experts, and we want to always ask this question, because I think for us, when we started this project, it was also like, what is this optimal performance? Everybody talks about we have to do optimal. We're not maybe looking perfection. We're not doing this, and we kind of like, but that's where the name also came from. Like, what is for you optimal performance?
That's a very good question. And you know, back in my athlete career, I kind of learned that it is very difficult to achieve your optimal performance exactly at the second it counts. And this is the thing that makes maybe the most important difference between the successful athlete and the less successful athlete. And I learned that if you want to achieve your perfect performance right at the moment, then you risk to fail. And this is something I can't risk during my surgeries. I can't risk to fail. And I do not have to try to do miracles. I'm just a normal guy, and I have to do my normal work. And if I do want to do something very special in a special case, I risk too much to fail. So my key for success is to do basic work and to keep it simple, to keep it steady, keep it always the same, because that gives you some security. This gives you, you know what you're doing, gives you the routine, and with that you will achieve a good result, and the good result will in the end be an optimal result.
Now, that makes perfect sense, and you know, it's in a real world or in an ideal world, it's easy, right? It makes sense, but I guess it's not always the same and so simplistic in operating hall.
No, of course not, but maybe this is even more philosophic than technical.
Absolutely.
But if you have an athlete that is famous and you go into the OR and you have to do surgery, the pressure is already very high. And if in this moment you try to do something special, you fail. In this moment you have to rather step back and be even more basic than you're used to, and just do what you do in every case, or treat every case as a special case, but do it always the same, keep your routine, and this will give you the good result.
Maybe also a little bit like too abstract question, but what's the difference between a good surgeon and an average surgeon? And I know it's difficult. It's in every field, you know. But you know, from because I'm working manually a lot, and you know there is still very big differences also on manual skills. What one can do, and I'm not saying somebody is not good. It's just I'm sure there is specific areas that one can be better than the other one. For example, today we're talking about the foot and ankle, specifically ankle joint, and you are specialized in this, and you've done some big surgeries. And I think it kind of like you also have to at some point ask yourself, okay, what is my strong point?
Yes, of course, and I think well, technically, first is knowing the anatomy, and second is having experience. There is a saying that says good results come from experience, and experience comes from bad results. So experience has to be learned, and I think it's important to deal with your experiences to improve, to question yourself what was good, what was not good, how can you improve. This is very important. But I think the key point is you have to have your diagnosis correct. And if your diagnosis is fine, then your therapy will be fine. But if you do surgery and you are not sure about the diagnosis, then you risk to fail. And this is, so for me, the success of a therapy, being surgery or being not a surgery, being conservative treatment, is to have your right diagnosis. And therefore, you have to stay with your getting the patient history, getting the clinical examination, getting the images, diagnostic things, getting a biomechanical analysis, but you have to be sure with your diagnosis, and from then on you can decide on your therapy and you will be successful.
Andre, can diagnosis change or not?
Yes, they can, of course. There is always time can change it, and this is difficult, because I see my patient maybe for half an hour or maybe for a little bit more, but maybe he comes to see me after having had for problems for 1 year, and I see him for half an hour, and I have to give him a diagnosis and to treat him, and sometimes it's useful to see him a second or a third time, and this is very important.
So why for you chose ankle and the foot? Because I mean, I know that you do also surgeries in knees and hips, but I think your bread and butter mainly is foot and ankle, right?
Yeah, it's maybe also a philosophical question, but I came into that, and the more you know about something, the more questions you have, like you have about achieving optimal performance, I got more and more questions about foot and ankle, and the more questions I had, the more interesting it got, and so I came deeper and deeper into these topics, and that's how I got my experience, and that's how I came to that. I think there are always a lot of different things that are interesting, but when the deeper you get into it, the more interesting it gets.
I guess also in surgery, or for surgeon, it's very important to have a specialty, or not? Because I guess when I look it from outside, and being here with you a few times, it's like you have to really know exactly what you're doing, and I think you can't know a whole body from shoulder to foot, to all the procedures and everything, because often it's actually even confusing a little bit from outsiders, like why we have a foot surgeon only, like.
Yes, I mean, it's obvious, the more you do one type of surgeries, the better you get, the more experience you get, and my time is somehow limited, and I can see a certain amount of patients, and the more I see in the foot and ankle area, the more I know about those, and then I don't have enough time for all the other things, and the specialization gets more and more. I see also some disadvantages of it. You can be too much specialized, I think, and it's important to have also people who know about the general things, and it's important that you do not only see your special problem, because it's possible that somebody has a foot and ankle pain because he has a low back pain or a low back problem. So if you just see your foot, you can miss some diagnosis too. So you always have to have your eyes open and to question your diagnosis, your treatment, to see if you're true. But of course, the more things you see about a special area, the better you get.
I guess also at what you said here, it makes completely sense now, is that in human body nothing works in isolation, right?
Yes, absolutely. I think this is very important, and this is one thing. And the other thing is that in athletes, you have to know it's not only about statics, it's not only about examining your patient on your bed, but it's having your patient, examining him in dynamics, seeing him, how he's doing the motion. Sometimes it's important to see how the accident happened. It's important to see how a motion is going on. So for example, somebody who is doing high jump, the foot is loaded completely different with the foot he's jumping off than with the other foot, and an injury can be very isolated to such a problem. So it's very important to understand how your motion is going on, to see the problem.
And today we will for sure see some injuries happening, right?
Yeah, we can have a look at some cases to discuss what happened in these cases, to discuss also the problems that are maybe linked to that, and see if we can get some ideas about it.
So I guess now we will talk a little bit about the basic anatomy of the foot, right?
Yeah, we'll talk about the anatomy a bit, maybe also in these cases,
yeah.
To see what's about it. Maybe I brought you some golden rules I like to use. Maybe we can have a look at these.
So let's have a look at the golden rules. So I put this on. It's coming up soon. Hopefully, there we go. And now we go in here.
I call it, these are my 3 golden rules of diagnostics, and it's a bit things we have been talking about now. Show that to you, let's see if I can go on.
Sure, you can also...
What happens if I go?
Well, normally things work, and it worked when we did it before. Let's go out again. Let's see.
I can tell you them also without showing you the slides. So my rule number 1 is you only search for what you know, and you will find only what you know, what you search for. So this is what I wanted to tell you before. You have to know a lot about your anatomy, about something happened, so that you know what type of diagnosis are possible. And when you have this diagnosis, you will search them and you will find them. But if you don't know about something, you will not find the diagnosis. And this is, for me, the basics that you have to ask. So let's see if it works. It's a bit.
So you talked about the first rule, right?
Yeah. So this is my rule number 1, and if I have a patient and I'm not sure, like I said, I always like to see him twice or 3 times. If a patient comes back after a treatment we started, for example a conservative treatment, and we see after 2 months how it's going on, and and he comes back and it didn't work, I always start from the beginning. I'm not questioning myself. Did I ask the right questions? Did I think about the right things? And I start to rethink everything before I just go on. Rule number 2 is I always try to find or to agree with the patient history, with my clinical findings, and with my additional diagnosis I have chosen. These 3 things, if they agree, I can be quite sure that the diagnosis is correct. And as I told you, this for me is the key that also my therapy is successful. But if patient history is something, but your clinical finding does not show what you expect from your from the patient history, and maybe your additional diagnostics like X-ray or an MRI or an ultrasound does show you something different again, and then I risk very much that my results of my therapy will not be perfect, because I don't know, do I have to guide my therapy to the patient history or to the clinical findings or to the other findings. This is very important. And the third thing is, if you have your patient history, if you have your clinical examination, and then you ask for additional diagnostics, you do your X-ray, you do your MRI, you do your biomechanical analysis, you have to ask the right questions. What do you want to see? And when you get the results, always check them for yourself. I see so many cases where a radiologist or somebody who did the analysis, who does not know about the patient history and the clinical findings, he sees something in the images, but he does not see what you were looking for, and this can be a problem. So always have a look yourself, not at the report of the diagnostics, but on the data itself, on the images, on whatever.
Getting there. The pictures are coming up. Almost there. So I think we can actually now put the pictures up. But so you can maybe keep talking a little bit more about the maybe some procedures or something once I get this up here. And it's coming up here. Good. Right. There we go. And now we can bring you over here. Good.
Okay. Maybe we can have a look at the first case that I brought to you. Let's see if it works.
Yeah.
Can I switch here?
So you went kind of through these, right? Or you want to go out?
Yeah. We can have a look at this case. This is a case to illustrate rule number 3. It's a patient I saw just recently. He had a calcaneal fracture, as you can see, fixed with this plate and screws 9 months ago, and he came to see me because he had a lot of pain. He couldn't move his subtalar joint, it was completely stiff, and he was standing in a valgus.
So if you're talking about subtalar joint, what do you mean with this?
The subtalar joint is the joint between the talus and the calcaneus. So it's the joint controlling inversion and eversion, and also having a lot of effect on the pronation and supination, of course. You want to have a look? We have a foot, not a very anatomical one. It does not move. We have a look here. So we have the ankle joint, or the upper ankle joint, that is doing the motion up and down, basically, but it's in details it's also three-dimensional, but in general it's going up and down. And we have when we look from the back, we have the subtalar joint between calcaneus and talus, and it's making the eversion and inversion.
So basically turning the foot in and out.
Yes. And so this patient didn't have any motion in eversion and eversion, and he saw his surgeon again because it was painful and he couldn't move. And this surgeon had a look and said, "Oh, maybe you developed some osteoarthritis," which is very common in these cases, of course. And he even made a CT scan, and the report of the CT scan was, "Oh, you have osteoarthritis." And he said, "Okay, we have to do a fusion."
So osteoarthritis is basically a degeneration of the bone,
yes,
right?
Degeneration, destruction of the joint, and therefore it's painful and doesn't move. And in the subtalar joint, the only solution is in an end stage situation to do a fusion of these two joints, so to block this motion. And this was suggested to this patient, and that's why he came to see me. And nobody had a look at the CT scan that was actually done. And now when you have a look at these two pictures of the CT scan, you see that the joint, let's see if I can show it to you, maybe like this. Yes, I can show it to you. You see, this is the upper ankle joint. This one this was not injured, and this is the subtalar joint here below the talus. And you see that actually the joint lines are basically fine. There is a little bit of a destruction on the lateral side, but most of it is really nice. But you see here there is a screw going through the joint, fixing the talus, the other side as well. And so there is no surprise that this joint is not moving, because there is a screw going across and fixing it. But nobody realized it. And so this is just as an illustration. Always have a look at the images yourself. When you had, you know the patient history, when you know the clinical findings, you have a completely different look at the images, and you will find a lot of solutions of your problems.
Basically, how old is this patient?
This patient is 50 years old.
Okay, yeah. And he or she was walking around with screw which was basically misplaced.
Yes. For 9 months.
Yeah, and I guess that was the initial problem for the pain.
That is the main problem for the pain now.
Yeah, exactly.
Yeah. Well, we will have the proof soon. We will remove the screw next week, and we'll have the proof when it's removed how much it will improve. But I'm sure he will win a lot of quality. It will not solve all problems. These fractures have a high risk of long-term sequelae, of long-term problems. But at least 9 months is not long term; it's very short term, and will improve the situation.
Okay, now that's really interesting, because it's even from my point of view, when you look at it, like you can see that this screw is for sure in between those two joints.
Yes.
And when I'm looking at this, I will be like, should that be there? And then I will be calling Andre. Do you think this screw be there? Because it doesn't look correct. Because if you want the motion in between those two joints, subtalar joint, then this screw shouldn't be there, right?
Yeah.
Okay, cool.
Okay, and now let's have a look at our first video, maybe. How can you open here the?
Yeah.
I hope it works.
Bring it up here, right here. So I think this one. Yeah. And now, which one you want? You can choose yourself. We have a huge list, but we won't go through them all, right?
No, we are not going. Let me quickly see.
Should be there, I think.
Yeah, but I have a file called video, and somehow it's not there.
Where did you save it?
I don't know. Okay, let's have a look at another video. Another case. This is a case.
So with this one, you can actually make it big before.
Yeah. So here you see this runner coming in. It's an orienteering competitive runner. He had actually an accident just before the video started. It's at the European Championships a couple of years ago. What do you guess? What do you think what he has?
I think he has a foot problem.
He does have a foot problem. Does he have a severe foot problem that he's running like that?
I don't have enough information to answer this question, but I would say most likely yes, because they are tough, so he wouldn't be hipping there like this.
Yeah, that's true. He, maybe still it's a surprise, he had a complete rupture of the Achilles tendon just some meters before, and you see he still can run, and this is something very interesting. Normally you think, okay, Achilles tendon rupture, nothing goes anymore, but that's not true. And sometimes it's surprising what is possible with injuries. Luckily he was close to the finish, so he didn't have to run for a long time.
I actually have a similar example from hockey. The guy played hockey with a fully ruptured Achilles.
Yes. It's,
so they are tough, you know, if
yeah,
they're in the
tough.
notice.
Yes. So this is not his Achilles tendon. This is a normal Achilles tendon rupture. It works.
Wow,
it
nice.
works. So you see, I'm moving the foot of this Achilles tendon rupture. You see, it's not a nice cut. It's a very uneven rupture. And this is very typical because all of these ruptures have some degenerative aspect of the tendon too. And what I want to show you is, this is something that is a lot discussed nowadays, is do these tendons need surgery or not? Mm-hmm. Obviously in this case we did.
So what tendon is this one there on the?
The small tendon is the plantaris longus tendon. It's some remnants of our past. The monkeys use it to keep the trees, so to not fall off a tree. Mm-hmm. For foot and ankle surgeons, it's the tendon is very nice because we can use it for reconstructive things. Sometimes I use it for reconstruction of the ligaments, or it can be used for reconstruction of some defects in the Achilles tendon.
So this tendon, this Achilles tendon now coming back, is completely ruptured.
It's completely ruptured. And you see, if we do conservative treatment, these two ends, they have to stay together for at least 6 weeks so that the scar can be built up, mm-hmm. and that it can develop some stable situation. And as you can imagine, once moving your foot too much, it can break up all your scar and you start again. And this has the high risk that your Achilles tendon gets too long, and when it gets too long, your lever arm is not optimal. And with not having an optimal lever arm, you risk to lose strength.
And the lever arm, if you say that, what do you mean with this?
The lever arm is the muscle tendon unit. So it's the Achilles tendon, it's your gastroc and soleus muscle, and it's the attachment proximal. All this has a function by it has to move your foot, and if this muscle tendon unit gets longer because your tendon gets longer, your muscle does not have the optimal optimal area where it can work. So it is not able to produce that amount of force that you want to have, or that could be possible. Maybe you know this the function unit of the muscle, the sarcomeres. They have optimal areas where they can develop optimal force, and if the length of the tendon changes, the force length relationship of the sarcomeres is not optimal, and this leads to the problem that you lose a lot of force because you are on the ascending limb, and on the ascending limb of the force length relationship you lose a lot of force. So if we want to achieve optimal performance for a patient in such a case, it's important to do surgery to reconstruct the optimal length of your Achilles tendon.
So you're saying in these cases it needs to be surgery. There needs to be a surgery.
In athletes, I always recommend to do surgery because we do not only want to have a tendon that heals, we want to have a healing in the perfect length, and second, we can start much earlier with motions because we have the sutures inside that keeps the two ends together, so we don't risk that we rupture all the scars again. So we can start with motions much earlier, and we have less loss of function, and our rehab will be shorter.
How fast the surgery needs to be made?
Surgery needs to be made within the first days, but it's not an emergency surgery that you have to do it in the first few hours. This is, of course, the healing starts at that moment you do your surgery. So the longer you wait, you lose some time. But on the other side, you have to have a good timing. You don't do the surgery in the night. Do it by day, do it with your staff that is prepared for that, so that you have an optimal quality. It's not only your job, it's also your team that has to be together, that has to be prepared. Surgery is not a one-man show, surgery is a team show, and this is important.
And how would you then put these things together now? You would just suture them together like this and that's it?
Yeah, there are different techniques how you do it, but I basically combine two techniques. First, I put all the small aspects of the tendon together, do a texture to put it together, and then I put a big suture all around to keep who is fixed in the good tendon, so that I have some security that the small adaptation, the small reconstruction does not have too much load and it cannot fail.
Okay, and how big is the risk is re-rupturing again?
It's not very high. The risk of re-rupture is less than 5%, but of course there are cases, and in my experience most of the cases happens within the first 3 months. You can be too aggressive in rehab at that moment, and then it can before the tendon healing is strong enough, you have the risk that it's loosening up.
What's the main mechanism for this injury to occur? What do you see?
Typically it happens not in the very active athlete, because there the tendon is stronger, it's adapted to the load. Typically it happens in former athletes who still have their performance in their mind, and then they try to do the performance again, and it for sure needs some extrinsic loading. It needs some jumps, and it happens in landing, not in jumping off. A lot of patients tell that they had some calf problem before, so there must be some additional tension on the muscle too. And sometimes you find pre-existing problems, being either tendinitis, tendinopathies, being treatments. For example, what should never be done in Achilles tendon is injections with cortisone, because that weakens your tendon. There are some antibiotics like ciproxine that weakens your tendons, and there the risk is higher to have an Achilles tendon rupture. Yeah.
So is this a common injury? You see that often?
Yeah, I see it quite frequently. Yeah, it's not it's quite frequent. Yeah.
Mm. Yeah. Okay, cool. Did you have something else?
Yeah, maybe we can go on. Let's see quickly. Go down. Yeah, this was the rupture of the athlete we have seen, and you see this rupture looks a little bit different. And he is also not the typical patient, but you see that in this Achilles tendon it's like a lightning. So it's not like oblique, but it's like all through the tendon, completely split up. And he actually had a risk factor, and that's maybe also a bit the reason why it happened like that. And I can show you this part. This ruptured exactly at the insertion of the heel down here, and he had at the heel area he had a bursitis. He had a inflammation of the insertion because he had some exostosis, and this was maybe the reason why it happened.
And the exostosis is an overgrown bone, basically.
It's an overgrown bone that leads is the main cause for this bursitis, and the bursitis weakens over time your tendon, and this may be the reason why it ruptured in this case.
Okay. And this you said that it's now pretty much from the insertion point, right? Yeah.
So this area is from the insertion point, and it went all up and here into the muscle of the calf where it ended. So it was like a lightning hitting a tree all through, split apart.
Can you say there is like a better option when you want to rupture your Achilles tendon, and if you can choose, which one I need to choose?
I wouldn't recommend either of them.
Okay, cool. But basically both are similar in severity, even though the other one maybe looked easier to repair maybe, but I guess here it's more difficult because you have to go along the line to suture it, right?
Yes, the basic problem of tendons is that the tendons heal very slow. The tendon structure is a lot of extracellular matrix, more than 90%, and cells is very little. And there is very few perfusion, very few circulation, and so healing goes on very slowly. So that's why tendon injuries are never good, and that's also the reason why it takes a lot of time to heal and come back. This is to compare like an ACL rupture for the comeback.
Okay, good.
Maybe we quickly go on. See. This was the reconstruction done in the surgery.
Can we maybe put it also big screen? I think it looks pretty interesting. So everybody, if you're watching it there already and it's looking, we should have maybe warned you before we went into this. I know it looks interesting, and once you're in the surgery and you see these things, actually, how do you get used to this? I mean, I was in there, and it was difficult at times to, it's blood and, things, and then you still have to be quite robust and things. And then I was like, a little bit dizzy at times. And now you look at the pictures there, and it's like, this is awesome, but...
The good thing is that I don't see the whole patient during surgery. I only see the anatomical structure I want to deal about, and then you're very concentrated and you never think of. But I had the same experience when I started my surgical career. So when I was the first time in a surgery, and it's quite odd. And at that time you have time to think. When you're doing the surgery, you don't have time to think. You're concentrated, and that's the big advantage.
One thing I learned going into surgery is that you should never go in hungry. Because there was a third time I came in hungry, and I was I think 1 centimeter off really fainting and then going down.
Yes, but on the other hand, it's not good to eat all the time. Because still it's hard. It takes a lot of energy, but you don't. It's not like doing sports. So it's good when you had a hard day of surgery to do some sports in the evening. Yeah. Otherwise, I have to see Lina, and she has to give me some nutritional tips. Yeah.
Good.
So
here you basically what you're doing is in different positions, right? The foot is or
yes, we in this case we fixed the part that has been ruptured off the heel. Yeah. We fixed through the heel in a transosseous refixation. We reconstructed it, and we put in also some. You see that on the right side. We put in some platelet-rich plasma to stimulate healing, to have a fast healing.
Do you think that works?
It works in some areas. It works. There is some literature that shows that in Achilles tendon ruptures there is a good level of evidence that it helps. But of course, if you have these ruptures, you have a lot of bleeding, and bleeding has also this aspect. So yeah, I don't know how much, but at least it's not a disadvantage to it.
Cool, sure. Okay, and then this the one in the middle and on the right, this is already fully then sutured.
Yeah.
And all these black lines, these come off or they stay in there?
These are sutures that are resorbable. So after a couple of months, they are resorbed and then they are gone. Yeah.
Okay.
I don't like to work. There are also non-resorbable sutures. Sometimes you have to use them, but I don't like them because athletes are young patients, and you are never sure when you have to go back, when there is something new, and then I like that this is gone, and so I like to put some resorbable sutures.
Okay, yeah. Cool. And then from him, the rehab and everything, how long that will be before he's back and running?
It's a very nice actually story of his comeback. It went very well. He had crutches for 6 weeks until with partial weight bearing in a special walker until we started to build up the rehab. Of course, we started with alternative trainings right away, and we started to train the other leg. We started to train the trunk and the upper extremity right away. And after 6 weeks, when he had full weight bearing, basically started his training, his endurance training with biking and in the water with deep water running. And about after 3 months, he started with running. Slowly, of course, but he improved very fast. And this is dangerous. You always have to warn your patients if they are going too well. You have to warn them even more if they are not going that well. And it happened in this patient as well. He was so good that after about 5 months he went to a training camp because he wanted to prepare for the next World Championships. And he came back, and then he called me and said, "Oh, Andre, can I come to see you? It was so nice, but now I have a pain in my forefoot." And of course I had my alarm signs going on and said, "Yeah, of course, come to see me."
Sounds like a fracture.
And I examined him and palpated his third metatarsal, and it was very painful. And I said, "Oh, you have to have an MRI. I'm not sure whether you have a stress fracture of your third metatarsal." And of course he had. And it was very typical because the elasticity of the tendon was not bad, not back yet. So he had a good strength. That's why he could load it quite a lot. But the elasticity was not the same. And so the motion in the ankle joint was not the same yet. And so the forefoot had to compensate. And then it's always the third metatarsal that has to load much more than before. And that's why he had a stress fracture of the third metatarsal, who took him out again for another 5 or 6 weeks. And well, he was back after 7 or 8 months. He was running World Cup again, finishing in top 10. But it took him. He told me later, only after 2 years I completely forgot about it. So it takes quite a lot of time to, there is a difference of being back and being completely without problems. And such a tendon injuries on a very high level, it takes 2 years to completely forget about it.
I completely agree with you here. Is that sometimes I always have this feeling that if the patients are healing too fast, I'm like, there's something is going to happen now, because you know the body needs a certain amount of time to go through some stages. Because we know there is, for healing, for whatever tissue it is, it has certain stages it needs to go through. And if you take a top level athlete off training, for example, 3-4 months, the body changes very fast. You know that the bone structure starts to change because the load changes, and so on and so on.
I think this is maybe an important message. It's not only about the injured tissue. It's all of the tissues around your joint, and of course all the body. They are all in a steady state, and that's why nowadays a joint is watched like an organ. So all these tissues are in a steady state. So if you have an injury, for example, you have to unload your leg. It's not only your tendon that is changing. Your muscle is changing. Your bone is changing. Your ligaments are changing, and all these they have a different speed of building up again, and you have to respect the slowest, and this needs time, and you can be too fast. I think this is something very important, and athletes have to learn that. You see a big difference in athletes, whether it's their first injury or it's their second or whatever injury. With the first injury, they feel like, every day I cannot train, I lose so much, and they want to be back so fast, and normally they are too fast. And if you are, if they have seen themselves that if they take their time, if they do their rehab well, and if they really invest in rehab, they will come back stronger than they were before. Then the next time they know how to deal it. And you can talk to them as much as you like. They have to live it themselves to understand.
Yeah, I think that's one of the things is that you can tell as nicely as what you want, but eventually they need to go through certain stages before they start to understand and listen to their bodies, because you know for them it's the performance they want to bring, but the performance always need a precursor, and this is the health of the function of the body.
Absolutely. And I know I have so many stories about athletes that didn't want to listen, and I tell them all the time, but some understand, and normally these are the athletes that come back stronger, and some do not understand, and then they have to learn it themselves.
Good. Yeah. Good. Did we have some other cases, pictures, videos, interesting?
Yes, we can have a look at another case. This is an interesting case. It's a young gymnast, and he had an ankle sprain while coming down. Actually, I don't know the
bars?
From the bars maybe. And the interesting thing is, and you have to understand what mechanism happened. And this athlete, he didn't have a supination, he had a pronation injury.
And when you say supination, pronation, you mean the foot is in which position then?
For a supination, it's like maybe I can. It's better to show my own foot. So supination is this type of injury. This happens like in 90%, and this type of injury, it's a pronation, and they are much more rare, but they have normally huge loads. So the energy is much higher than in a lateral ankle sprain. And basically this patient also, he felt that it's rupturing something. And the foot was swelling and he couldn't load it, and it's, you see, I called it acute on chronic. He had some sprains before, and he had very lax joints, so that he had some risk factors too, but he had a severe injury, and he had an X-ray to exclude fractures, and then he had an MRI done. And this is interesting because this shows another problem in foot and ankle sports medicine. Normally on the MRI you do not find like one thing, you find like 4 or 5 things, and you have to understand what's the problem. And when I make this small, that I can explain to you the MRI. So pronation makes the medial ligaments dangerous, and you see here, this is the medial ligament complex.
So that's the inside, right?
The inside, and you see it's all ruptured through.
So that's the darker.
Yes,
area.
normally it's here. These lines should go through, and you see how there is a rupture, and the liquid is going all through. But you do not only see that, you see that the cartilage, this gray line here, stops. There it's white, it's not gray anymore. You see some irregularity here going through. And then when we have a look at the next slide, in these axial views, you saw some special things here that looks like tendon, but it's not. Here there is no tendon. And these are loose bodies, loose bony bodies swimming around in your ankle joint.
And so they got loose from the impact, right? No?
In this case, I'm even not sure. I actually thought that they were pre-existing.
Okay.
And this is what you see in this next slide. These are intra-arthroscopic views of his ankle joint. On the left upper side, you see the inner side. You see the complete rupture of the deltoid. Now I have to make it small to show you.
You can maybe go bigger, maybe here, so it's a little bit bigger. Yeah.
Oh yes, good. So you see here, this is the talus, this is the malleolus from the inner side, and you see here the ligament all ruptured through. But you see also on the inner side of the malleolus here should be like very nice cartilage, looking like this side, but it's all destroyed, and there is all a huge cartilage defect. And you see here, this is the area, the cartilage area where the joint is loaded. This is the talus, this is the tibia. Oops, I moved it. This is the tibia, and you see this big spur. So there was a piece of bone completely destroying this cartilage down to the bone. And on this side here, you see these were the loose bodies swimming around in the joint, making blocking sometimes. So this is something. So there was a chronic injury before, but now a new acute one on top. And for a 20-year-old athlete, this joint is really destroyed. And this is something very difficult to deal, because of course the athlete wants to go back into training, wants to go back into competition. Maybe he can, but he will have for sure some long-term sequelae. And so high-level athlete or high-level sports is not always healthy. And
mostly, I guess.
And this is something you have to know, or you have to discuss with your patient, and it's difficult whether you should recommend him to stop, or if you recommend him to go on. Maybe there is just a black and white, so either he goes full power or he stops, and there are arguments for both sides, because his joint will not be completely normal again at any time, also if he stops, and so this is very difficult. And this is very typical in the ankle joint with ligament problems. In chronic cases, you find cartilage injuries, you find tendon injuries, you find loose bodies, and all these things have to be brought together to have a good therapy or a good treatment in the end.
So even though we're saying it's just a foot or ankle, or actually just 2 or 3 joints, it's actually the whole combination of these multifactorial impacts, plus everything, whatever happens in foot goes directly to the knee, hip, and low back, and so on and so forth. So the foot is a very vital ground or base for the basic human function, right? So if this is not functioning good, you know that at some point you will start getting problems somewhere else.
Yes. Yeah. Absolutely. Yeah. Absolutely.
Do we have something else?
We have maybe to finish up. We have a quick look to the future.
To the future.
Yes.
Ooh, I like future.
Wait, I want to show you this. This is the future I'm working on with a company called Vertamed. Is it running or not? No.
It's not running, I think.
Let's see, maybe this one movie should be. Oh no, it stopped. Maybe it's not the future yet. So no, we are working on it. It's called virtual arthroscopy. Quickly, where is it?
So that's kind of like then a technology or something.
Yes.
To help. Okay, no, that looks really interesting.
Yep.
It's down there, exactly. And now, if you've been watching this, we're soon gonna go quickly and have a look if there is any questions. So we're gonna do a quick answer question session if there is any questions. So type them in if you have something, and yeah, otherwise. So the video is not functioning.
Video is not running, but I can explain to you.
Yeah.
So this is a virtual tool where you can train your arthroscopic skills. It's already existing for knee and shoulder joints, and it's a very good learning tool. And I think with that you can improve a lot your technical skills.
Mm-hmm.
And I'm together with Vertamed, I'm developing this virtual arthroscopy for the ankle joint as well. And I think that in future there will be more therapies possible arthroscopically, and the less you have to injure all the soft tissues around for surgery, the better your result will be. So I am hoping that this will be a new step for good treatment options for athletes.
How does it work? It doesn't make sense to me.
It's very similar to the what you do like in video games.
Uh-huh.
So you have your arthroscope in your hand,
yeah.
But it has all what you see on the screen is like virtual. So you have like you see here, you have down here there you have an ankle or a foot with an ankle joint, but inside it's empty, and you are putting your arthroscope and your instruments in, and you can do your treatments, whatever, and it's reacting on what you do, and you get a feedback.
So this is like a more like a learning machine.
Yes,
exactly.
It's to improve your training skills, and maybe also to train new things. So before you go into the patient, you can do that, practice a lot, and you can improve your skills, or you can try what is possible, maybe develop new tools that you can do new type of surgeries.
Good. That sounds actually interesting. Even so, if you get one around, I'll come and play with it. It sounds very interesting. So let's have a quick look if we have any questions from our viewers on Facebook. As I had to do a restart for the whole system here, then half of the system is not up and running, but it's coming up soon.
Hopefully the online it worked.
Online is working.
Okay.
Online is working.
Okay.
That's for sure. That's for sure. Anything else you had in mind? You feel like the message should go across?
I think we could talk for hours.
Exactly, that's the thing. I'm looking at these pictures and I'm like, oh, this is so interesting. I could keep asking you questions, but we're almost like an hour or almost.
But I think to come back or to the most important things is to have your diagnosis right, and for that you need to get your patient history, you do your clinical examination yourself, you have to watch the diagnostic results yourself, and then you're good. And it's maybe not that important whether the treatment is conservative or if it's surgical. It has to be to be aimed for your diagnosis, and then you will get a good result.
And for you personally, what's been one of the most complicated, or what's a complicated surgery? If we're wrapping this up with a nice little difficult question before I get to the questions here.
That's actually very difficult to answer.
I guess every surgery is a little bit, to his own degree, is a little bit difficult.
Every surgery is different, of course.
Yeah.
Every surgery is different, and I think when you're sure about what you do, and you do step by step, then it's fine. I think the most difficult cases are where when you have factors from outside influencing your performance, and this is difficult. And when you have factors like there is pressure, there is maybe time pressure, there is some other pressures, but when you have your time and you can take your time and you are sure about what you're doing and you're experienced in that, then it's a technical thing, and then you can achieve optimal performance.
Good. And to wrap this thing up, I'm so happy that and thankful that you agreed to take part of this project. We are still at the beginning of this journey, and we have still many places to visit and go. But the beginning has been really interesting, and I for sure have learned many things from you also from today and also before. And I feel fortunate to have you on my phone list to be able to call if I have problems with ankle and foot generally. So I'm really thankful for that, and for your time tonight after a busy day. Actually, how many surgeries you had? You said 6 surgeries before. Yeah. 6 surgeries, and then now he's in here. So I really appreciate your time and your thoughts. Thanks for that.
Yeah, Martin, thanks a lot. It was interesting from you too. And actually, I'm very interested in following up you on your journey too. And it's a great idea to do something like that, to focus on such a question. I think you will learn a lot of it, and it will be interesting to learn too from you. Perfect. As well. Thanks a lot.
Thank you. So, thanks for watching. Achieving Optimal Performance is done for tonight with the foot and ankle, but in 2 weeks we will go into golf. We go to Ireland, where there is big winds going and blowing tonight. So hopefully everything will be okay in few weeks time when we are in close to Dublin, Ireland. And we will talk about golf, but it's not only about golf. It's going to be a lot about rotational athletes and what to use as exercises and what not to do and certain things. But we will talk more about this this week's or next week's 5-Minute Friday, which is our weekly show where we talk everything we did the week before or so. And yes, thanks a lot for watching us. Share our good message, and let's spread the good word about healthcare and optimal performance. Have a good evening, and thank you very much.